not only renal disease, but also if you see most of the, like one of the, even though it's a rare disease, it's not that rare. All pediatricians will encounter nephrotic syndrome once in a while, and some of them are not very straightforward, some are complicated. We'll listen to Dr. Shabri, who's a very old friend and a good friend of mine. He has completed his MBBS from Kozhikode Medical College, and after that he came to SAT for his research and DNB. Then he has done his DM in nephrology from Government Medical College Tirunelveli itself. And for the last 7 years, has been a practicing nephrologist whose keen interest is in pediatric nephrology as well as kidney transplantation and glomerular diseases. Over to you, Shelby.
Thank you, Dr. Radhika. Am I audible?
Yes.
Visible?
Keep it slideshow. Slideshow.
Okay. Is it okay now, sir?
Okay. Okay.
Good evening, everybody. My most favorite teachers from pediatrics, senior pediatricians, my dear friends, especially moderators, both Radhika, Dr. Radhika and Dr. Rehana, both are my friends and very well known to me. I'm very familiar. And we will go to the topic because I think the time is up to 9:30. We will go to the topic directly. And we all are familiar with the nephrotic syndrome in childhood, childhood onset nephrotic syndrome, and quite confusing at some time because of various definitions, differences in the treatment guidelines and all. And we will simplify this topic today, and it's all very, very well known to all of you. And I will be covering only the steroid sensitive nephrotic syndrome mainly, because most of you are dealing with the steroid sensitive nephrotic syndrome, and the steroid resistant varieties will be sent to the pediatric nephrologist usually. So we will be covering the steroid sensitive nephrotic syndrome in childhood today, the updates. And we will be going through definitions, various definitions in nephrotic syndrome, childhood nephrotic syndrome, and how to evaluate renal biopsy guidelines, management therapy in first episode as well as relapses, and management of hypovolemia and edema, and coming to the complications like infections and how to tackle those infections with immunization. And there is no nephrotic syndrome without these definitions, you all know. And what is nephrotic range proteinuria? That is urine albumin 3+ or 4+, or urine PC ratio more than 2 mg per mg in first morning urine specimen, or proteinuria more than 40 mg per meter square per hour. And what is the remission in nephrotic syndrome? That is urine protein nil or trace, urine protein creatinine less than 0.2 for 3 consecutive early morning specimens. And what is relapse? That is urine protein more than or equal to 3+, or urine PC ratio more than 2 mg for 3 consecutive early morning samples after a remission. What is frequent relapses? Some change in this definition, that is 2 or more relapses in the first 6 months after stopping initial therapy, or more than or equal to 3 relapses in any 6 months after the initial therapy, or more than or equal to 4 relapses in an year. Coming to steroid dependence, that is 2 or more consecutive relapses when on alternate steroid therapy or within 14 days of discontinuation of steroids. Steroid resistance is lack of complete remission despite therapy with steroids with daily prednisolone at a dose of 2 mg per kg daily for 6 weeks. That is the current guideline, 6 weeks. Stable remission is sustained remission or infrequent relapses during immunosuppressive therapy. Coming to the complicated relapse associated with life-threatening complications like hypovolemia or severe infections. And difficult to treat disease, that is frequent relapse or significant steroid toxicity with frequent relapses or significant steroid toxicity with even with infrequent relapses, or failure of more than or equal to 2 steroid sparing regimen. That is difficult to treat disease. While going through the next slides, these definitions or these words may come, and I have already explained all these definitions just to make you familiar with this when coming through the next slides. And what are the differences in guidelines or differences in definitions through various guidelines? In ISPN 2008, Indian Society of Pediatric Nephrology 2008, nephrotic syndrome was nephrotic range proteinuria along with hypoalbuminemia less than 2 point albumin less than 2.5 gram per deciliter with cholesterol more than blood cholesterol more than 200 and edema. This was the definition in 2008 by ISPN. When it comes to ISPN 2021, it is nephrotic range proteinuria, hypoalbuminemia less than 3 gram per deciliter and edema. There is the serum cholesterol is not included in this definition. And when it comes to KDIGO 2021, it is nephrotic range proteinuria with either hypoalbuminemia, and hypoalbuminemia is 3 gram per deciliter, or edema, either edema or hypoalbuminemia. They have relaxed the guidelines actually. Coming to the evaluation of nephrotic syndrome, at the onset of disease, definitely we will have to go for urine analysis along with complete blood counts, renal function test, total protein, albumin, total cholesterol, and we have to rule out the presence of any tuberculosis with tuberculin test just prior to the starting of corticosteroid therapy. And additional evaluation may be required, especially at the onset of relapse with chest X-ray, renal USG, complement C3, C4, ANA, ASO titer, especially in case of hematuria or sustained hypertension, suspected secondary cause in some children. And what are the guidelines for kidney biopsy? We all know that more than about 80 to 90% of the children may not need kidney biopsy, especially if it is steroid sensitive. And when we move with kidney biopsy, it is when there is presence of persistent microscopic hematuria or gross hematuria or presence of persistent acute kidney injury. And presence of systemic features like fever, rash, arthralgia, low complement C3 may also warrant renal biopsy. Corticosteroid resistance, there is no doubt we will have to go for renal biopsy, whether it is initial or late corticosteroid resistance. Late corticosteroid resistance means initially there was response to steroid therapy. Later on, with some relapses, there is resistance to the corticosteroid therapy, and we will have to move forward with steroid therapy. Renal biopsy. And prior to the initiation of therapy with CNA, that is cyclosporin or tacrolimus, we will have to definitely go for renal biopsy to assess the status of the kidney. And prolonged therapy with CNA or presence of persistent kidney dysfunction with CNAs, we have to go with renal biopsy. And for all renal biopsy, we will have to order for light microscopy and immunofluorescence, and electron microscopy may be needed in some cases. And the regular teaching is that above 12 years, if there is nephrotic syndrome, we may need, or we will have to compulsory, we will have to move forward with renal biopsy. But nowadays, even within the adolescent age group, we can go without kidney biopsy, especially if it is steroid sensitive. And if there are no unusual clinical or lab features, we can go forward with steroid therapy without any kidney biopsy. But if there are some unusual features, or if the steroid sensitivity is not there, we may have to think of kidney biopsy. An infant less than 12 months of old, usually, first of all, we will have to go for genetic testing rather than kidney biopsy and all. And frequent relapses also, biopsy not advised before initiating steroid sparing agents except CNA. For all other agents, before starting those agents other than CNA, you need not go for kidney biopsy, like MMF, levamisole, rituximab and all. You need not go for biopsy, but prior to CNA, you will have to go for renal biopsy. And coming to the therapy for the first episode of nephrotic syndrome, that we all know, there are no much changes. Initial episode should be treated with prednisolone at a dose of 60 mg per meter square per day, or 2 mg per kg per day, maximum 60 mg in 1 to 2 divided doses for 6 weeks. This was the earlier teaching, and now also the same thing. It should be followed by 40 mg per meter square or 1.5 mg per kg, maximum 40 mg as single morning dose. On alternate day therapy should be a single morning dose. That is always advised for the alternate day therapy, single morning dose for next 6 weeks. And for children, rather than weight-based dosing, it would be advisable if you go with the body surface area dosing, because weight-based dosing can lead to underdosing in young children, especially in young children. And nowadays, with so many of mobile apps and all, calculation of body surface area is not a difficult thing. So you can go with body surface area calculation and go with the steroid dosage. And for the therapy for relapses, and relapses to be treated with prednisolone at 60 mg per meter square per day in single or divided dose until remission, and it should be followed by 40 mg per meter square on alternate day for 4 weeks. That is the dictum. And for the relapses, this should be followed. And for the relapses treatment, there is no much difference in opinion between various guidelines. Coming to treatment of frequent relapses and steroid dependence, and some change in definition, I have already told, change in definition of frequent relapses. And in 2008, ISPN has given the definition as more than or equal to 2 relapses in first 6 months after stopping initial therapy, or more than or equal to 4 relapses in 1 year. And in 2021, they have included more than or equal to 3 relapses in any 6 months also, along with the previous definition. And KDIGO has come into picture, and KDIGO has make it very much simple that frequent relapses is more than or equal to 2 relapses in 6 months, or more than or equal to 4 relapses in a year. That is the definition by KDIGO. And what we should do for the frequent relapses or steroid dependence? We need not go to the steroid sparing therapy directly. You can go with an initial strategy of low dose prednisolone. That is, prednisolone at a dose of 0.5 to 0.7 mg per kg on alternate days can be continued, and later taper to 0.2 to 0.3 mg per kg on alternate days for up to 6 to 12 months. You can give, and you can see for the response of the child, and you can see, watch for the relapse in between. And if some infection, some upper respiratory infection or respiratory infection come, you can give the alternate day therapy dose on daily basis for 5 to 7 days. That is the rule. So this is the initial strategy for frequent relapses as well as steroid dependence. You can continue the treatment for up to 12 months. That is the initial strategy. But some difference in guidelines between ISPN and KDIGO. Prolonged alternate day steroids, ISPN has given in 2008, they have advised to taper to 0.5 to 0.7 mg per kg for 9 to 18 months, some longer duration. But later they have reduced it to 6 to 12 months. But KDIGO is not at all advising this long-term therapy just because of risk of toxicity. But for the children, usually we follow ISPN guidelines, 2021 guidelines. So I usually give 0.5 to 0.7 mg per kg alternate day for 6 to 12 months, and in between I usually taper to 0.2 to 0.3. Most of the children respond to this regimen, and they go very well with this. And after stopping the therapy also, they will be devoid of relapse for so much of months, and they are also very much happy, and we are also happy. Rather than going to the some steroid sparing regimens and making it more complicated, I usually go with this prolonged alternate steroid therapy for 1 year. And already told, during infections you can give. In 2008, there was no recommendations for this during infections for the daily therapy. And in 2021, ISPN has given the guidelines as to give that steroids daily for 5 to 7 days if it was being given for alternate days. And KDIGO have given a little bit different guideline. That is, even if the child is off steroids, you can give daily therapy for 5 to 7 days. And ISPN has given that if the child is on alternate days prednisolone, you can give for daily for 5 to 7 days. But if the child is not on off steroids, they haven't given any guidelines. But KDIGO has told that even if the child is off steroids, to prevent the relapse, you can give the 5 to 7 days daily therapy for children with nephrotic syndrome. That is the difference between these two guidelines. And when to consider steroid sparing agents? And there is no doubt it is frequent relapses and steroid dependence. But even if there are fewer relapses, as per the definition, the relapses are fewer, but the child has significant steroid toxicity, take it as frequent relapse and treat it as frequent relapses only. Don't wait for the definition. That is the guideline. And another thing is that if there is only occurrence of 2 relapses in 6 months while on long-term therapy with steroids or steroid-sparing agents, you can take it as a frequent relapse and go and treat it as frequent relapse only and go with the steroid sparing agents. And when it is steroid threshold more than 1 mg per kg on alternate days or more than one complicated relapse. Complicated relapse means there was some complications like infections, like peritonitis, hypovolemia and all. You have to select some steroid sparing agent, or if there is significant steroid toxicity is there, if the steroid threshold is more than 1 mg per kg, or if there was more than one complicated relapse, or there is significant steroid toxicity, you go with mycophenolate mofetil or cyclophosphamide. And if the steroid threshold was less and there were no complications and there is no significant steroid toxicity, you can go with levamisole or mycophenolate mofetil. And in my personal experience, MMF is a very good choice, and most of my children are doing very well with MMF without any side effects and all. Only thing is that you have to monitor their blood counts. Usually I give blood counts weekly in the initial days, later monthly blood count monitoring, and the parents itself can be make them aware of the cutoff and make them aware that they should inform us if there is some leukopenia and all. MMF is a very good drug for the frequent relapse as well as steroid dependence. And this is the flow chart. If frequent relapsing or steroid dependent nephrotic syndrome, you have to give the prednisolone on alternate days for alternate days prolonged therapy, and you have to make it daily during infections. And if it is steroid toxicity with frequent relapse, steroid toxicity of frequent relapses, and the threshold is more than 1 mg per kg or more than one complicated relapse with a significant steroid toxicity, you can go with mycophenolate mofetil or cyclophosphamide, or if it is there is no much toxicity or the threshold is less, you can go with levamisole or MMF. And if it is difficult to treat disease, that is need for more than 2 steroid sparing agents or severe corticosteroid or frequent relapse with even with the steroid sparing agent, you can go with cyclosporin or tacrolimus or rituximab. That is the regimen. That is for the difficult to treat disease, choose cyclosporin, tacrolimus, or rituximab. And the one thing we have to remember is that cyclophosphamide should be avoided in children less than 5 to 7 years old or peripubertal boys. And prednisolone may be tapered and stopped over 6 months, except in severe steroid dependence. Even if you are using the steroid sparing agent, you have to use the prednisolone at a low dose for about 6 months and then taper and stop. And if there is severe steroid dependence, you can prolong the therapy with prednisolone. So you should not stop the prednisolone at all of a sudden. Please continue steroid at a low dose for some time. And some useful tips. Levamisole may be more useful in frequent relapses and steroid dependence. And MMF is comparable to levamisole but inferior to cyclosporin in frequent relapses as well as steroid dependence. MMF is more efficacious in young children and more effective than levamisole in steroid dependence. So for levamisole, you should keep it for frequent relapse, and MMF you can keep it for steroid dependence as well as frequent relapses. So that is an important tip. And for the cyclophosphamide, is few points. That is, it is more effective in frequent relapse than steroid dependence, and leukopenia is the chief adverse effect. And alopecia and risk of infections is there, and there is a high risk of gonadal toxicity, so we should avoid in peripubertal boys. And it should be we are giving the oral cyclophosphamide, and it should be limited to 12-week course, and cumulative dose is up to 168 mg per kg. And coming to the calcineurin inhibitors, cyclosporin or tacrolimus, it should be given for difficult to treat cases, and it can be considered in young children less than 7 years with steroid dependence or frequent relapses when it is very difficult to treat. And you must always remember that, and you have to counsel that there is a high rate of relapse once this drug is discontinued. So while discontinuing the therapy also, you have to counsel the parents that there is a high risk of relapse. And rituximab, only few points. It can be used in steroid as well as CNI dependent nephrotic syndrome. It is very useful for sustained remission. It can give a result up to 25 to 70% of sustained remission, and there is a good efficacy for frequent relapses too. And repeated doses may be useful to sustain remission. And there is a risk of infusion reaction, infections, and hypogammaglobulinemia. And we have to give prophylaxis with cotrimoxazole or trimethoprim in these cases. Even in some centers, for the initial therapy also, that is for the initial episode of nephrotic syndrome also, childhood nephrotic syndrome also, they are giving directly giving rituximab. And I have no such experience with this treatment. Hope Dr. Radhika or Dr. Regina can give some tips at the end. And these are the various immunosuppressive medications, and these are the doses. And we must be aware of the various side effects of all these drugs. And it is 100% that there would be some side effects, especially with the steroids. And some of them are tolerable and some of them are intolerable. In those cases, we will have to go for steroid sparing agents. And for other agents also, mainly leukopenia is the main side effect we are always observing, and so we have to closely monitor them with counts. And for the CNAs, cyclosporin and tacrolimus, for the calcineurin inhibitors, there is a risk of nephrotoxicity also. So renal function monitoring is also very important. Also dyslipidemia, hyperglycemia, all these metabolic side effects also can occur. So we must be aware of that and we have to monitor. A few words about steroid-resistant nephrotic syndrome. For SRNS, that is steroid-resistant nephrotic syndrome, calcineurin inhibitors are the first choice of therapy, and we have to continue therapy for at least 24 months if there is partial or complete remission is achieved. If there is no remission, please stop the drug even before 6 months of therapy and counsel the parents and monitor them with the renal function test. And we will have to make them aware that the child may need renal replacement therapy in the future and even renal transplantation. And other agents useful in SRNS are IV cyclophosphamide, rituximab, and MMF. Coming to the supportive care, just a minute. Hypovolemia and edema. Edema can be mild. What is mild edema? It is weight gain less than or equal to 7%, and moderate edema is 8 to 15% of weight gain, and severe is more than 15% of the weight gain. And there can be intravascular volume depletion also along with edema. That is the most complicated thing that we are observing. Because while there is edema, it's very difficult for us to assess the volume status in a child. So if the edema is moderate to severe, there can be a chance that there is volume depletion also. So it should be assessed before you give the diuretics. And which are the clinical features in hypovolemia? Main clinical features are abdominal pain, vomiting, lethargy, prolonged capillary fill time, tachycardia, low volume pulse, low BP, and all. And biochemical features are elevated hematocrit, phenol less than 0.5, blood urea creatinine ratio more than 100. And now in the era of focus, that is point of care ultrasound, you can use the ultrasound machine to assess the volume status. With decreased IVC diameter or increased collapsibility index, you can assess the volume status in a child. This is how you can assess the hypovolemia. And if the edema is mild, what you can advise is to restrict the dietary salt. And for the moderate to severe edema, first, along with the dietary salt restriction, you can give oral furosemide in the dose of 1 to 4 mg per kg per day. You can add spironolactone if the furosemide dose is prolonged to avoid hypokalemia. Again, if there is refractory edema, you can add metolazone in the dose of 0.2 to 0.4 mg per kg per day, or hydrochlorothiazide, and you can add even IV furosemide 1 to 2 mg per kg bolus and repeat at 12 hours. And even you can use the infusion at a dose of 0.1 to 0.4 mg per kg per hour. In case of refractory edema, you can use IV albumin 20%, 0.5 to 1 gram per kg over 4 hours, followed by IV Lasix, that is IV furosemide 1 to 2 mg per kg at the end of infusion. In case of refractory edema, you can use isolated ultrafiltration also. And this case is very rare. I have never used this ultrafiltration in any child. Hope I think in SIT and all they had to use. They may have to use in some difficult cases with edema. Hypovolemia, you can treat with IV normal saline 10 to 20 ml per kg over 30 minutes, and you can repeat it if the child is hypotensive. Again and again hypotensive, you can repeat the bolus of normal saline, and followed by oral and IV hydration and IV albumin 0.5 to 1 mg, 1 gram per kg over 4 hours. What are the reasons of diuretic resistance in nephrotic syndrome? This is a very common thing, because even if with high dose of diuretics, child may be having severe edema. This is because of diuretic resistance. These are the various reasons. This is because of maybe because of poor adherence to salt restriction and reduced availability of oral furosemide, and can be due to hypoalbuminemia, because this furosemide has to bind with albumin to reach the kidney loops. And hypovolemia also can be a reason, because there will be less circulation to the kidney, so drug may not be reaching the kidney. And there may be compensatory salt reabsorption in the distal tubule, and gut edema may be one of the cause, because there may not be adequate absorption of the drug, and impaired tubular secretion of the diuretic is also another reason for diuretic resistance. What are the infectious complications? 20 to 40% of the hospitalization in childhood nephrotic syndrome is due to infections. Different infections like peritonitis, pneumonia, cellulitis, and all. Cellulitis is very common, and sometimes it becomes a nightmare also, these infections. And use of reasons for recurrent infections is that use of immunosuppressive medications, anasarca, these high volume overload, can be a reason for recurrent infection, because this fluid and all may be a culture medium for the infectious agent. And due to urinary loss of IgG and complement factors also, this child may be immunosuppressed, and suppressed, and they are more prone to infections. And these are the main infections: peritonitis, pneumonia, cellulitis, sepsis, and varicella infections, very common. And peritonitis is mainly caused by Streptococcus pneumoniae, Strep pyogenes, E. coli, and pneumonia with Streptococcus pneumoniae, Staph aureus, Haemophilus influenza, even with H1N1 and influenza viral infections. And tuberculosis also more common than other children. And cellulitis with Staph, Streptococcus, Haemophilus influenza, and gram-negative bacteria. Child going into sepsis and septic shock. And varicella zoster virus infections also very common. And you can treat the peritonitis with ceftriaxone or cefotaxime for 7 to 10 days. You can treat the pneumonia with, you can start the treatment with oral amoxiclav. And if it is not responding, child is not responding, you can go with parenteral therapy with ceftriaxone or ampicillin and amikacin combination for 7 to 10 days if the renal function is normal. And for H1N1, you can use the oseltamivir. And cellulitis, you can use co-amoxiclav. Both oral and parenteral can be used. And for the sepsis, you can give the combination of ceftriaxone and amikacin for 10 to 14 days. And varicella can be treated with acyclovir also. And coming to immunization, you can give age-appropriate kill subunit or inactivated vaccine to these children at any time. But for the live vaccines, there are some certain principles you have to follow. And you can also opt some specific vaccines against pneumococcus, varicella, influenza, and hepatitis B. These are the principles of immunization. If the child is receiving high dose of prednisolone, but the duration is less than 14 days, you can vaccinate immediately after discontinuing the treatment. But if it is more than high dose is more than 14 days, after discontinuing the steroids, you have to wait for 1 month to vaccinate. Vaccinate with live vaccines. And if the child is receiving low to moderate dose of prednisolone, that is less than 2 mg per kg per day, no live vaccines until discontinuation of steroid therapy. And in case of low dose alternate prednisolone and there is a need for vaccine, pressing need for vaccine is there, you can give the live vaccines then and there itself. Otherwise, you can wait till the discontinuation of therapy. And patients receiving cyclophosphamide avoid live vaccines till the end of therapy, after the therapy, after 3 months of therapy. And for the patients receiving calcineurin inhibitors, levamisole or mycophenolate, you have to wait for 1 month after discontinuation of therapy, after stopping the therapy. And for the therapy with rituximab, you have to wait till 6 to 9 months till there is B cell recovery. And for the immunocompetent siblings and household contacts, do not administer oral polio vaccine, and they can receive other vaccines like measles, MMR, rotavirus, and varicella vaccines. And for the household contacts older than 1 year, they should be given influenza vaccine annually to avoid cross infection. And these are the specific vaccines: pneumococcal vaccine, both conjugate as well as polysaccharide vaccine, varicella vaccine, influenza vaccine, and hepatitis B vaccine. For the completely immunized child, more than 2 years of old, if the child is completely immunized before that, 6 to 72 months of age child, completely immunized child, you need to give 1 dose of conjugate vaccine only when the child is more than 2 years of old. And you can give another dose of unconjugated vaccine, 23 valent vaccine, if the child is more than 2 year old and after 8 weeks of initial conjugate vaccine. And if the child is more than 72 months of old, that is about 6 years of age, and it is child is completely immunized, you can give 1 dose of unconjugate vaccine only. Need not give conjugate vaccine. If the child is incompletely vaccinated, immunized, or unimmunized, you can give 1 dose of conjugate vaccine followed by 1 dose of unconjugate vaccine with an interval of 8 weeks. And for the varicella vaccine, you can give after 15 months of age. If there is no evidence of immunity, you can give live attenuated vaccine, 2 doses, 4 to 8 weeks apart. And influenza vaccine can be given after 6 months of age. It's an inactivated vaccine, you can give annually. And hepatitis B vaccine has to be given in an accelerated schedule. 3 doses has to be given at 0, 1, and 6 months, or in an accelerated schedule with more than or equal to 4 weeks gap between doses 1 and 2, or more than 8 week gap between doses 2 and 3, or more than 16 week gap between doses 1 and 3. This is the accelerated schedule in hepatitis B immunization in nephrotic syndrome. A few words on post-exposure management of varicella. This is very, sometimes there can be a query with us for a nephrotic syndrome child with an exposure to varicella. What should be our next step? You can give varicella vaccine within 5 days of exposure if the vaccine is not contraindicated. And varicella zoster immunoglobulin is another option if the vaccine is contraindicated, which has to be given within 10 days, preferably within 4 days. And the dose is 125 international units per 10 kg of body weight. And maximum you can give up to 625 international units. And if both of these are not available or you are not able to give both these, you can even give oral acyclovir 80 mg per kg in 4 divided doses for 7 days, and which has to be begin 6 to 10 days after exposure. And IVIG also is possible, which has to be given within 10 days of exposure, 400 mg per kg. And I feel I have covered most of the areas in steroid sensitive nephrotic syndrome, and hope the whole topic was uh, was was understandable to you, and any queries and can be discussed in this forum. Thank you very much.
Thank you, Shabri. That was a wonderful presentation. I think you simplified things and you also compared all the guidelines. The floor is open for discussion.
Thank you, Dr. Shabri. That was a wonderful talk. There are some questions in the chat box. The first one I only posted. That is whether the PCR ratio has to be done consecutively for 3 days. Is it a new change or previously it was there? Usually,
PCR ratio usually we do only once. In some guidelines, they have given it as 3 days, consecutive 3 days. They advise to do, but we usually do only one PCR ratio. And we advise to do the urine albumin for 3 consecutive days. That's all.
okay. And steroid treatment after 6 weeks daily and 6 weeks alternate day. You don't have to taper. Only 3 months you can give. I can stop after 3
Yeah,
months.
6 weeks, 6 weeks. You can immediately stop after that. But most of the times, sir, it's individualizing the therapy would be good. You can, if the remission was little bit delayed, I usually give this alternate day therapy for little more days and taper to a lesser dose and taper slowly. And even though the guidelines is like that, if the remission was delayed, it would be better. You can delay the or you can prolong the alternate day therapy for some more months. What about Radhika ma'am? What do you say?
For us, basically, we taper and stop in all cases, irrespective of the response duration. Actually, the guideline actually does not ask you to taper and stop, but it's a practice that we've been following. Mostly, it is adapted from the adult practice because the idea is when you give steroids for any other indication, usually you taper and stop. So why not for nephrotic syndrome? So that is the rationale that we Shabri will also agree that in adults we always follow that
Yeah, yeah.
rationale. So same this thing we are practicing in pediatrics also because there is no guideline saying you should not taper and stop. So what we do is usually we continue 6 + 6 weeks and then taper over the next few weeks.
Okay, I heard in one conference that the longer you give in the first episode, the lesser chance of relapse. Is it
Yes,
true?
there were some earlier studies which showed that the first episode, if it is treated with the tapering regimen, the relapse may get delayed. The next relapse may get delayed. So that is another
So
reason
the
why we
thing
do.
is that sir, cumulative steroid dose becomes very high because these children may get relapsed again and again. We will have to use the steroids, and the cumulative dose becomes very high. That is the problem. So that's why they have given for a shorter duration of alternate therapy
No, but
also.
Shabri, when they have a relapse, again you are forced to use a full dose steroid. So again, it's a daily steroid. So
Yeah,
basically,
yeah.
you need a randomized control trial to say that which is better, stopping without tapering or abrupt stoppage.
And why cyclophosphamide is avoided in 5 to 7 and prepubertal age? Please, sir. Cyclophosphamide is
Cyclophosphamide.
avoided in 5 to 7 years age and in the
Uh,
prepubertal age.
I feel that it's just because it's less effective in smaller children and in pubertal boys to avoid gonadal toxicity. And for the in studies, they have found it that MMF would be more effective in smaller children than cyclophosphamide, and
Once
severe
you
side effects can be avoided with by avoiding cyclophosphamide in smaller children. That could be the reason.
and how long you give MMF?
MMF should be given for 2 years, sir. At least 2 years.
Thank you. Hari had a query in the chat box.
That is regarding DM1 and type 1 diabetes and nephrotic syndrome, steroid sensitive nephrotic syndrome. What should be the strategy how to go with steroids in a child with the DM, type 1 DM?
Type 1 DM, that problem would be hyperglycemia, would be uncontrollable. That is the problem. Only thing is that we can monitor the blood glucose and give the insulin, but you'll have to go for steroids only. There is no other choice. Only the monitoring and giving insulin at the adequate dose is the only thing that we can do. Radhika ma'am?
Thank you.
Yeah, if I may add to that, as Shabri said, we'll have to use steroids to treat it and induce a remission. But sometimes what we have done is in patients who have diabetes as well as nephrotic syndrome, we have, after inducing remission and the patient continues to have relapse, sometimes we have gone just beyond the
Steroids.
definitions and started MMF
MMF, that would be
to
ideal.
maintain the remission.
Because all other CNAs also have the risk of hyperglycemia. MMF is the ideal agent which does not usually make the blood glucose so very elevated.
But MMF cannot induce a
MMF could be
remission.
the
So
ideal
we'll
thing.
have to use steroids to induce remission and then
Yeah,
maintain the remission with MMF.
all these steroid sparing agents have to be used once the child is in remission only. That would be
Except
ideal.
CNI.
And what about levamisole?
Levamisole can be used in frequent relapse and it can be used, sir.
Okay, thank you.
Dr. Radhika, shall I read? There is one more query in the chat box. Shall I read?
Yes, sir.
In case of moderate to severe edema, why not use albumin 5% instead of 20%? Any latest guidelines? Shabiri?
No such guidelines, sir. All the guidelines they have given only 20% albumin. No, 5% albumin is not. I have never read about that. Whether is there any difference and all? But 20% albumin would be better for maintaining the euvolemic status. To avoid the hypovolemia, 20% albumin would be the better thing.
Actually, it's not the percentage. It is actually the dose is 0.5 to 1 gram per kilogram, up to a maximum of 20 grams. So it is not actually the percentage which is important, but the amount. So when you give 5% albumin, obviously the volume will be higher. And in nephrotic syndrome, we want to use as less volume as possible. So that is probably why 20% is preferred.
Okay. Any comments from Dr. Ehana?
Excellent talk, Dr. Shabri. I just wanted to add one thing regarding that type 1 diabetes and nephrotic syndrome. I had few patients. So I was going through the literature, all those things. So sir was mentioning, Shabri sir was mentioning regarding using rituximab upfront, like as a first choice. So there was some data, all are like anecdotal reports where they have used, of course, not in very small children, but adolescents with type 1 diabetes and nephrotic syndrome. They have upfront used rituximab without using steroids. So there was some case reports on that. So there was a mention about using rituximab upfront, and that is being practiced among some adult nephrologists. But we usually follow steroids. Steroids and look at the course and then decide. But maybe we'll go for steroid sparing agents early because of the anticipated steroid related hyperglycemia in those patients. So that is the thing which I wanted to just add. Excellently presented, very clear and very crisp. Thank you.
Thank you.
This using rituximab early upfront is actually a very controversial thing now running in pediatric nephrology circles. We recently had Dr. Prasad Devarajan from the US with us. He was saying that probably they will move on to using rituximab even before starting steroids. So that is the way they are thinking now.
Yeah.
Rituximab should be the first line agent because it gives a prolonged remission. and it avoids the side effects of steroids.
Yeah.
But I really don't
But
know if it will
long-term
be.
side effect, there are no much studies on long-term side effects of.
One is that, and second is
rituximab
in our
because-
place infection is still a big problem. We have
Yeah,
lost. We use rituximab a lot,
And the
but
chance of
once in a while we
malignancy
do
also for
lose
the
a
children when
patient
they
for it with
grow
infection.
old.
So I don't know with our infection profile if rituximab would be that safe a drug. I guess for at least for a long time we will still start with steroids.
Selectively, can you give rituximab?
Sir?
Selectively, can you give rituximab depending on the patient?
Yes, sir. We use a lot of rituximab, especially for high dose dependence and in between for steroid resistance also. For high dose dependence, it gives a very good response. But still, our protocol is not to use it as upfront. We will go in a graded manner, like from steroids to MMF, then calcineurin inhibitors, either TAC or cyclosporin, and then go for rituximab. We usually reserve it as the last drug.
Is it cost effective, madam? And for long time use, it is cost effective?
Yes, it is. It is actually very cost effective because the CD20 reconstitution actually takes only 6 to 9 months. By that time, the CD20 is reconstituted. But even then, many patients go on for prolonged remission. We have patients who have had rituximab and after that never relapsed. We have had patients who have rituximab then relapsed after, like say, 2 years and all. But some patients will relapse exactly at 6 to 9 months.
Yeah,
So
yeah.
that
One of my
response varies between patients, but whoever has a response who has sustained response is very cost effective. Even for 6 months, if they don't get any relapses and they get off drugs, it's a very good thing. So cost effectiveness is not an issue. The issue is with the side effect profile. Like sometimes we lost a patient 2 years back. It was a well-grown child who only had serodependent nephrotic syndrome for it, and we lost her for a pneumonia, which did not respond to any antibiotic. So that happens once in a while.
And rituximab is available at a cost of 500 mg at a cost of even 9,000 now, and we will need only up to 4 doses, I think, maximum. And
You give only 2 doses,
2
at
doses,
weekly intervals.
maximum 4. And sometimes, as Madam told, they may relapse at exactly at 9 to 12 months, and we may have to repeat the dose at that time. That is the other.
Sumida? Sumida is there?
Sir.
So there are no other queries. Even the official vote of thanks is over, but we are very much obliged to Dr. Adhika, Dr. Hena, and Dr. Shabiri, a nephrologist from our own place. So we look forward to see you all in our place physically someday for any conference. So thank you, Dr. Adhika, Hena, and Dr. Shabiri, for the wonderful
Thank you,
talk.
sir.
Thank you, sir.
Thank you.
Reminder. Thank you.
Thank you all.
Thank you.